Welcome to the Pediatric Pharmacy Association Core Competency Module on Pediatric Pulmonary Hypertension. My name is Elizabeth Beckman, and I'm the current Pediatric Cardiac Critical Care Specialist at Kentucky Children's Hospital. I will be guiding you through this module in hopes of expanding your knowledge on this complex disease state and deepening your understanding of the pharmacotherapy of pulmonary hypertension. I do want to disclose that I am currently a consultant for the Pediatric and Neonatal Lexicomp, as well as serving on the board of pharmacy specialties for the Pediatric Specialty Council. The objectives and outcomes of this presentation include reviewing the pathophysiology, classifications, and diagnosis of pediatric pulmonary hypertension, as well as comparing and contrasting the medications for the treatment of this disease, in hopes that you will be able to apply the guideline recommendations to a child with pulmonary hypertension. Pediatric pulmonary hypertension, or PH, is a rare disease accounting for 2 to 3 new cases per 1 million children every year, with approximately 25 to 50 children per 1 million affected at any given time. This disease is progressive and it's terminal with a life expectancy around 2.8 years without treatment. Some of the demographics of PH are represented here. The average age of diagnosis is 7.1 years, with it predominantly affecting more female patients and has over a 90% ethnicity distribution in the white, Hispanic, and Asian populations. Idiopathic pulmonary hypertension is by far the largest subtype, but notably, 28% of children with PH have trisomy 21, and it's estimated that 35 to up to 58% of children with congenital heart disease and trisomy 21 have some degrees of pulmonary hypertension. Historically, the definition of PH in children has been the same as it is in adults. In the normal fetal circulation, pulmonary artery pressure is similar to systemic pressure and rapidly falls after birth, achieving similar pressures to an adult by 2 to 3 months of age. Due to the variability in that pulmonary hemodynamics during that postnatal transition, pediatric PH has been defined as a mean pulmonary artery pressure (MPAP) of greater than or equal to 25 millimeters of mercury in children greater than 3 months of age. The expanded definition of pulmonary arterial hypertension adds a few more measurements to consider. The MPAP is assessed through cardiac catheterization. It measures the pressure in the main pulmonary artery. The 6th World Symposium on Pulmonary Hypertension proposed to modify the definition of PH in adults to an MPAP of 20 to better identify those subgroups at high risk or those patients with borderline PH. This MPAP threshold of 20 has not been validated in children, therefore the 25 millimeters of mercury is the accepted threshold currently for our children with pulmonary hypertension. Pulmonary arterial wedge pressure is a measurement within the pulmonary arterial system when the catheter tip is wedged in that tapering branch of one of the pulmonary arteries. This pressure is a surrogate of the left atrial pressure, which represents the outflow or the venous pressure from the pulmonary circulation. Any increase in that left atrial pressure is transmitted back to the pulmonary capillaries. Elevated wedge pressure may indicate that the left side of the heart is failing, which is really imperative to identify because left heart dysfunction is not included in the PH definition, and some PH-specific therapies may actually worsen left-sided heart failure. Additionally, in pediatric PH, especially in those with congenital heart disease, it's recommended to use the pulmonary vascular resistance that's indexed per body surface area, or the PVRI, to assess the presence of pulmonary vascular disease, as defined as the PVRI greater than 3 Wood units. Idiopathic or hereditary pulmonary hypertension has no underlying disease associated with it, the PH development. And pulmonary hypertensive vascular disease describes PH that is really unique to the congenital heart disease population. These are the patients with the cavopulmonary anastomosis that are seen with your Glenn, Hemi-Fontan, and Fontan surgeries. These patients will have elevated pulmonary vascular resistance, oftentimes without mean pulmonary artery pressure elevation. Pediatric pH classification is currently categorized in a very similar fashion to that of adult pH, which is really based on the World Health Organization classification system. There are 5 groups to classify pediatric pH according to their etiologies. So beginning here at the top at the 12 o'clock position, group 1 includes those patients that have idiopathic as well as drug or toxin-induced congenital heart disease and persistent pulmonary hypertension of the newborn. Group 2 includes children with PH due to left-sided heart disease. Group 3 in that 4 o'clock position is PH due to lung disease or hypoxia, which would include those patients with severe bronchopulmonary dysplasia. Next is Group 4 with PH due to thromboembolic disease. And lastly, Group 5, which includes PH with multifactorial or unclear mechanisms. That includes those with hematologic or metabolic disorders. The 2 most common classifications found in children include Group 1, which accounts for about 87% of our pediatric cases, and then again Group 3, which constitutes about 11% of our pediatric cases. I wanted to quickly highlight this alternate pulmonary hypertensive classification found in children. This is the Panama classification system, which seeks to include the heterogeneous and unique disorders that specifically present during early childhood, and the importance of the chromosomal and genetic syndromes that we see in our children. Also, it takes into account the impact of the developmental mechanisms as well as the physiology and the multiple factors that are often associated with pediatric pH. This classification remains untested and not validated, but really it is poised for future study and consideration. Another classification that is useful in describing patients with pH is their functional class. The WHO functional class for pH is similar to other functional classes, such as the New York Heart Failure Functional Classification System. Class 1 describes the most active and the least limited patient, whereas Class 4 is the most severely restricted functional class, and those patients often have symptoms at rest and are unable to participate in activities of daily living. The limitations to this stratification are that it does not offer any developmental checkpoints, which makes it difficult to broadly apply to every pediatric patient across the age spectrum. However, you will see it used as a determinant of risk for classifying severity of disease in children with PH. The Panama Pediatric Functional Class is a modified version of the WHO's system. This Panama system assigns patients to one of 5 categories that are defined slightly different for these different age groups. So they are categorized by their age in groups like 0 to 6 months, 6 months to 1 year, and so on and so forth. This classification is yet to be validated and is not currently adopted by the active pH guidelines. You can find this classification in the 2-sided publications listed here. As I've said earlier, pulmonary hypertension is a progressive disease of various origins that is incurable and is associated with poor prognosis. Regardless of etiology, patients generally exhibit similar pathological changes. On the left side of this slide, you can appreciate the healthy cross-section of a pulmonary vessel. There's a wide open interluminal space, normal endothelium, and a smooth muscle layer. When you compare this to your figure on the right side of the slide, you can appreciate that there is vascular obstruction, there is enhanced pulmonary arterial constriction, endothelial dysfunction, proliferation of the smooth muscles layer, as well as remodeling of both the endothelial and smooth muscle cells, and some in situ thrombi as well. The physical outcome of these disturbances is the partial occlusion of those small pulmonary arteries, eventually that increases the pulmonary vascular resistance and subsequently leads to that right ventricular failure as well as death. Broadly speaking, pH is caused by a dysregulated vascular tone from reduced prostaglandin I2 production and nitrogen oxide synthase dysfunction, as well as concurrent vasoconstrictive and remodeling effects of an upregulated endothelial 1 signaling system. These signaling pathways, the prostaglandin, nitric oxide, and endothelin-1 systems, serve as our current therapeutic targets in this disease. We are fortunate that guidelines do exist to help standardize the diagnosis, treatment, and follow-up for children with pulmonary hypertension. The most current guidelines available from the American Heart Association, the American Thoracic Society, was released in 2015. However, the European Pediatric Pulmonary Vascular Disease Network also released a consensus statement in 2019 on the diagnosis and treatment of pediatric pulmonary hypertension. I would also like to note that the World Symposia on Pulmonary Hypertension Association meets every 5 years, after which a supplement is published of the proceedings, which often includes updates on the diagnosis and management of PH, even in children. The last symposia was in 2018, and the next one is scheduled for 2024. The diagnosis of PH in a child is about as much of a process of elimination of other etiologies as it is about meeting the actual PH definition. For a patient with suspected PH, we'll start here from the top on the left. They employ non-invasive screening diagnostics such as the transthoracic echocardiogram, electrocardiogram, and chest X-ray. If any of these tests are abnormal, further screening is employed to rule out primary lung disease, neuromuscular and connective tissue disorders. Pulmonary function tests, sleep studies, and even ventilation perfusion scans can be considered as well. Notice that there are no biomarkers mentioned, as there is a lack of data that can predict disease risk, severity, and disease progression in PH with children using biomarkers. Cardiac catheterization remains the gold standard for diagnosis and confirmation of PH in children. Oftentimes, catheterization is required to proceed with initiation of PH drug therapy, as many of these drugs are quite expensive and are protected pharmaceuticals by many insurance companies. Another gift the 2015 guidelines provided is a treatment algorithm that illustrates the pharmacological approach to pediatric PH. The asterisks in the italicized text represent the additions to this guideline from the 2018 World Symposium on Pulmonary Hypertension. We'll spend the rest of our time reviewing these PH medications and their place in therapy. So starting from the top on the left, we're going to review the general management considerations for children with PH. The guidelines provide 4 therapies to employ in order to optimize hemodynamics and cardiopulmonary interactions. First to consider is oxygen, which is necessary to prevent hypoxic vasoconstriction of the pulmonary bed. Next, we can consider diuretics, including loop diuretics, thiazides, and even spironolactone, to provide diuresis to achieve a decrease in preload and ventricular filling pressure in efforts to offload that right side of the heart and minimize pulmonary overcirculation. Anticoagulation decreases the risk of thrombosis, which is absolutely crucial when we're talking about the intraluminal diameter being decreased from that progressive remodeling of pH. Low-dose aspirin or warfarin are the typical agents that we use for this indication. Lastly, there's digoxin that can be considered in patients with right heart failure in order to offer some inotropic support. All of these therapies are supportive in PH and can be used in combination with the PH-specific therapies that we are soon to discuss. So during cardiac catheterization, acute vasoreactivity testing is employed to determine the degree in which pulmonary vasoconstriction is contributing to the elevated pulmonary artery pressures. Whether a patient is a non-responder or a negative test, or a responder, which is a positive test, this helps inform which pharmacotherapy options can be offered. In the next 2 slides, we'll be focusing on these positive vasoreactivity testings with the who and the what and the why. So in acute vasoreactivity testing, or AVT, short-acting potent vasodilators such as your inhaled nitric oxide, IV ibuprostanol, and adenosine infusions are utilized. Inhaled nitric oxide really has emerged as the vasodilator of choice due to its high pulmonary selectivity. It has a very short half-life and lacks systemic side effects. However, it is really expensive when you compare it to the others. The epoprostenol infusion is associated with systemic hypotension and headaches, as well as nausea, whereas IV adenosine is associated with systemic hypotension, in addition to chest pain and even AV block. The contraindications to AVT include a patient with functional class 4 symptoms and overt right heart failure or systemic hypotension. So to be classified as a responder or having a positive AVT, a patient has to have at least a 20% decrease in both their mean pulmonary artery pressure and pulmonary vascular resistance, or a decrease in their pulmonary artery pressures by 10 to less than 40 millimeters of mercury without a reduction in their cardiac output. Vasodilator responsiveness, or a positive AVT, identifies those patients with a better prognosis and those who are more likely to have a sustained benefit from calcium channel blocker therapy. It also allows the assessment for those congenital heart patients that may actually benefit from surgical correction to help mitigate their disease progression. One interesting study to note was a registry study that was international and looked at the current practices according to AVT response and using calcium channel blocker therapy. So this query of 31 centers described relatively low uptake of these guideline recommendations, with a report of the 59% of the responders not treated with calcium channel blockers and only 23% of the responders receiving calcium channel monotherapy. And 14% of those responders had calcium channel therapy, but they were also on other pH therapies as well. Calcium channel blockers may seem like an odd choice for treatment of pediatric PH because we think of them more for their cardiac properties or their peripheral vasodilatory effects. However, calcium channel blockers do relax the pulmonary arteries and decrease pulmonary vascular resistance. The place for calcium channel blockers in pH therapy are in those patients with positive vasoreactivity testing and they have idiopathic pH. The dihydropyridine, specifically amlodipine and nifedipine, are used most commonly, and sometimes the non-dihydropyridine diltiazem may be considered as well. We typically do not use verapamil because it's contraindicated for its negative inotropic effects, and it really doesn't have much pulmonary vasoreactivity properties. And it does cause bradycardia, which is undesirable. So this table lists the recommended dose, PK considerations, adverse effects, and dosage form considerations for the oral calcium channel blockers and pH. All these agents seem to have potential for hypotension. However, amlodipine probably has the less likelihood of causing acute hypotension following its dose due to its slow onset of action. Amlodipine may also be favorable compared to the other two, as it has the longer half-life and allows for that once daily dosing, and it does come in that commercially available suspension. Nifedipine may be preferred if quick titration is really necessary, as it has one of those shortest half-lives of all the dihydropyridines. However, the initiation and titration of nifedipine really should be done under the close supervision of a specialist provider due to that risk of severe hypotension. Additionally, the nifedipine solid dosage forms really are not ideal for that young child. The bite and swallow method of administering immediate release nifedipine is not recommended, as it may lead to this variability in the dose that's administered and result in significant hypotension. Diltiazem does have some additional considerations compared to the other two. It is a moderate inhibitor of the CYP3A4 system and may cause bradycardia. Compared to the other calcium channel blockers, diltiazem has been associated with more reports of cutaneous reactions, specifically hypersensitivity and photosensitivity, and really that should be included as part of the patient education counseling. Moreover, there are many different dosage forms available for diltiazem, which really makes the selection that difficult to provide the pediatric specific dose, but also allows that opportunity for medication errors if the wrong dosage form is selected, especially in those points of transitions of care. For a child with pH who has a negative ABT, calcium channel blockers will not be the agents of choice. Instead, this group will be classified into either low or high risk pH, which will inform the pH-specific therapy options below. The 2015 guidelines offer risk stratification based on a myriad of clinical findings. Right ventricular function, functional class, echo and cath findings, laboratory markers, and exercise testing are all considered when classifying a PH patient as a low or high risk or of decompensation or disease progression. Low-risk patients have less severe disease, as demonstrated by no RV failure, more favorable cath hemodynamics, and preservation of their activity level with their higher functional classes. High-risk PH patients, on the other hand, typically have right heart failure, poorer functional status and exercise tolerance, and unfavorable cath hemodynamics. The risk stratification of the negative vasoreactivity pH patient informs which pathway for therapy selection a patient may follow. The lower risk group may be initiated on an oral phosphodiesterase inhibitor or endothelin receptor antagonist, or an oral or inhaled prostacyclin agent. Combination therapy may be considered in this group per the World Symposia of Pulmonary Hypertension. Higher risk patients should be initiated on parenteral prostacyclin therapy with or without combination oral phosphodiesterase inhibitors and endothelin receptor antagonists. Phosphodiesterase inhibitors, endothelin receptor antagonists, and prostacyclin analogs make up the core therapies for pulmonary hypertension. These core pH therapies target one of the three pathways that contribute to the vasoconstriction and cellular proliferation that are the primary pathophysiologies of pH. The endothelin 1, prostacyclin, and nitric oxide pathways will be our focus for the next part of this presentation. Let's take a closer look at the nitric oxide pathway. In normal physiology, nitric oxide is an endogenous pulmonary vasodilator that is synthesized from L-arginine in the pulmonary vascular endothelial cells by nitric oxide synthase. It diffuses into the adjacent cellular smooth muscle cells where it activates the soluble guanylate cyclase. Guanylate cyclase is an enzyme responsible for synthesizing cyclic GMP, which is an intracellular secondary messenger that is responsible for a number of downstream effects, specifically vasodilation and regulating cellular proliferation. Riociguat is a soluble guanylate cyclase stimulator that sensitizes guanylate cyclase. On the other hand, phosphodiesterase subtype 5 is an enzyme responsible for the homeostasis of cyclic GMP-specific pathways. In pH, the expression and activity of PDE5 are increased, therefore leading to that increased catabolism of the cyclic GMP. Therefore, when you add the PDE5 inhibitors, such as sildenafil and tadalafil, this increases cyclic GMP concentrations, which promotes vasodilation and inhibits smooth muscle cell proliferation. The two available PDE5 inhibitors that are most commonly used in pediatric PH are sildenafil and tadalafil. Comparing these two products, tadalafil has the better bioavailability. However, when sildenafil is taken with a high-fat meal, the rate of absorption is delayed and the Cmax is reduced by nearly 30%. Tadalafil has the longer half-life when you compare it to sildenafil, which allows for its daily administration over sildenafil's 3 times a day administration. Both of these agents are substrates of the CYP3A4, which may have some drug interaction implications if other drugs are added. Both have similar adverse effect profiles as well. Hypotension, flushing, and headaches are the most common complaints of using these drugs. Of note, the visual disturbances that are most commonly described with using sildenafil and tadalafil are really dose-dependent and reversible impairment of the color discrimination in the blue-green and blue-purple range. Sildenafil is available in commercially available suspension and tablets, as well as an intravenous solution that was approved in 2015. Tadalafil, unfortunately, is only available in tablets, but there is an extemporaneous suspension available. So when discussing PDE5 inhibitors and pediatric PH, we really have to discuss the landmark START trial. In 2012, START-1 was published. This double-blind, multi-center international study randomized 235 treatment-naive children to either low, medium, or high-dose sildenafil or placebo 3 times a day for 16 weeks. You can review the dosing strategy in the box inside the chart. The primary outcome was the percent change from baseline in peak oxygen consumption for the 3 sildenafil doses versus the placebo. But this was only able to be performed in about half the patients because of their age and cooperation. The secondary outcomes included cardiac catheterization, hemodynamic changes between those dose groups at baseline at the end of the 16-week trial. The mortality was collected, but it really was a tertiary endpoint. Primary outcome was actually not met in this study. There was no statistical significant change in their peak oxygen consumption with the pulmonary cardiopulmonary testing. Similarly, there was not any change in the pulmonary artery pressures and pulmonary vascular resistance either. However, there was an improvement in functional class in the medium, and high dose groups. And also, the side effects were more profound in the medium and high dose groups as well. Patients from that STARTS-1 trial were offered enrollment in the STARTS-2 trial, which was a long-term safety study. The patients who were randomized to placebo in that first trial were randomized to either one of the 3 sildenafil treatment groups in this extension study. At the close of STARTS-2, all children had received at least 3 years of sildenafil treatment. The outcome of the STARTS-2 trial was survival. However, if you remember from STARTS-1, it was not the primary outcome. STARTS-2 reported 37 deaths, which accounted for 16% mortality across all the sildenafil treated groups. The majority of these deaths were noted in the high-dose treatment groups at 22% and the medium-dose group, which had a mortality rate of 14%. 40% of these deaths were patients with functional class 3 and 4, and 70% of those had a PVRI that would put these patients in a high-risk category. As you can imagine, this mortality information created confusion and commotion, and the FDA stepped in to comment. So in August of 2012, the FDA drug safety communication was released. This statement commented on this observed dose-related effect on mortality, with the highest dose having the worst outcome, and the lowest dose was not effective in improving exercise ability. The new warning against the use of sildenafil in pediatric patients was added to that branded Revatio drug label, and it specifically stated, use of Revatio, particularly chronic use, is not recommended in children. About 2 years later, in March of 2014, the FDA circled back and clarified their warning because it was brought to their attention that some healthcare professionals had interpreted the label warning as an extreme contraindication to using sildenafil for pulmonary hypertension. The report in 2014 stated that the recommendation was not intended to suggest that sildenafil should never be used in children, but the risk versus benefit should be weighed. Now, the STARS trial have a number of limitations that really should be addressed. There was large heterogeneity in these pediatric PH patients. They came of all ages, they had different etiologies of PHs, and functional classes as well. The inclusion criteria was constructed to gain efficient enrollment of this rare pediatric disease, but because of that, that's why you get that large heterogeneity. The START-1 trial was not powered for mortality. Remember, mortality was that tertiary endpoint, and the analysis of survival data was unadjusted for multiple confounders. Additionally, survival in the placebo arm was not reported, as the placebo arm in STARTS-1 was again randomized in STARTS-2 to receive sildenafil in one of those 3 doses. Nevertheless, the observed survival in all the groups was actually higher than the 3-year survival rates in pediatric PH before the availability of these PH-specific drugs. The sildenafil doses that were used in this study were scaled from adult PK data, which may be ill-informed dosing strategy for sildenafil for our wide spectrum of patients, which ranged from 1 year to 17 years of age. The serum concentrations were actually found to be lower than expected in the low dose group and higher than expected in that medium and high dose group. And lastly, by today's standards of practice, the guideline-directed management, functional class 3 and 4 patients would have been classified as high risk and referred to parenteral prostacyclin therapy instead of monotherapy with a phosphodiesterase inhibitor. So from a pediatric pH community perspective, sildenafil really still does have a place in pediatric pharmacotherapy. It's not necessarily the more is better mindset, but it still really is a valuable tool in this fight against pediatric pH. Riociguat is the latest nitric oxide pathway drug to be approved by the FDA. As the soluble guanylate cyclase stimulator, it supports increased cyclic GMP, which results in that desired pulmonary vasodilation. Riociguat has great oral bioavailability and is hepatically metabolized to an active metabolite that has about 1/10 of the potency of the parent drug. Dose adjustments are required for this drug if using concurrently with other CYP450 or PGP inhibitors. The half-life affords the 3 times daily dosing, and with only a tablet form available, it might not be the best choice for some of our children. However, these tablets can be crushed and mixed with water or soft foods, but caution should be used as this is a hazardous agent that requires single gloving for manipulation. Additionally, riociguat requires REMS program enrollment as this drug is associated with embryo-fetal toxicity. Lastly, there is an active industry-sponsored study called the Patent Child Study that is investigating the safety, tolerability, and PK of riociguat in your 6 to 17-year-olds with PH. The primary recruitment window closed at the beginning of the pandemic, and the full study results are still pending. The next class of medications we will examine inhibit the endothelin-1 pathway. Endothelin-1 is a potent vasoconstrictor at endothelin A and endothelin B receptors. Endothelin receptor A mediates arterial vasoconstriction, whereas endothelin receptor B seems to be involved in vasoconstriction on the venous side. Endothelin-1 also induces signaling through the epidermal growth factor receptor transactivation, which is involved in cellular proliferation, as well as it stimulates the production of reactive oxygen species. There are 3 endothelin receptor antagonists, which I'll refer to as ERAs, available on the US market. Ambrisentan inhibits endothelin-1 binding at the endothelin A receptor. Bosentan and macitentan block both endothelin A and B receptors. Of the 3 available ERAs, bosentan is used most frequently as it is the oldest of the 3, which was approved in 2001, and has alternate dosage forms that are compatible with younger children. These similarities of these 3 agents is that ambrisentan and macitentan have long half-lives that preclude the once daily dosing, whereas bosentan requires twice daily dosing. Since bosentan has an FDA label indication for pH in children as young as 3, the dosing is a little bit more robust. This is a simplified version of the labeled dosing table, and here you can appreciate that weight-based dosing may be utilized under 20 kilos, but rounding to a partial or full tablet size really is preferred. Of all of these agents are all hazardous agents, which complicates the manipulation of the tablets into partial sizes and making the extemporaneous suspensions. All are substrates of CYP3A4. However, bosentan is the only agent that is considered an inducer, and special attention to drug-drug interactions is necessary. All 3 ERAs have similar side effect profile. The embryo fetal toxicity requires enrollment in the REMS program for all 3, with bosentan having an additional requirement for the REMS program with monitoring for hepatotoxicity. Ambrisentan and macitentan do not have as high a risk of liver injury as bosentan does. Acquisition of these agents is typically done through a specialty pharmacy that has been certified by the agent's REMS program. I do want to note that macitentan is undergoing clinical trials at the moment to look at this drug's safety and efficacy in children down to 2 years of age. Those studies are listed in that blue box. REMS program compliance is really a big hurdle of using the ERA class. All agents require monitoring to mitigate the risk of embryo-fetal toxicity from unintentional or intentional pregnancy. Anal reproductive screening begins at age 8 in patients with a uterus, and monthly pregnancy tests begins once puberty begins, which is defined as Tanner stage 3 and premenarche. As for bosentan, this drug has been implicated in elevating ALT and AST at least threefold upper limit of normal in about 11% of patients, often accompanied by elevated bilirubin in a small number of cases. The liver injury can happen at any point during therapy, but typically resolves once the therapy is discontinued. Because of the risk of hepatotoxicity, bosentan REMS programs require monitoring of liver functions prior to initiation and then monthly thereafter. The final pH drug class involves the prostacyclin pathway. Prostacyclin, which is also referred to as prostaglandin I2, is an eicosanoid derived from arachidonic acid. Prostaglandins are released from healthy endothelium and have many actions, but for pH, those actions would be vasodilation and antiproliferation. In pH with a dysfunctional vascular endothelium, the expression and function of the prostacyclin is reduced, thus reducing cyclic AMP and leading to vasoconstriction and proliferation. The 4 drugs that are available that target this pathway are listed in these blue boxes. You have your prostacyclin analogs, which are epoprostenol, treprostinil, and iloprost, and your prostacyclin receptor agonist, which is selexipag. There are 3 prostacyclin medications available for the treatment of pediatric PH. These come in varying routes of administration, which offer both enteral and parenteral options. However, the stability and half-life of these products add additional challenges in agent selection. Epoprostenol was the first agent to be approved by the FDA. It's used as a continuous infusion or continuous inhalation, as its half-life is of 6 minutes or so, which necessitates that continuous administration. Iloprost is available as an intermittent inhalation solution, but with a half-life of 20 to 30 minutes, it still requires frequent administration. Treprostinil is the longest acting of the prostacyclin products, with a half-life around 4 hours. It also has the widest variety in routes of administration, including continuous IV and subcutaneous infusion, intermittent inhalation solution, a new dry powder inhaler as of May 2022, as well as an oral dosage form. The side effects of this class of medications are relatively similar across all the dosage forms, with the exception that the inhaled route typically is linked with coughing and the subcutaneous route is linked with injection site pain. Recall from the mechanism of action slide that prostacyclins bind to the IP receptor, which induces cyclic AMP production, thus leading to vasodilation in the pulmonary artery. However, the IP receptors are quite ubiquitous and are expressed in many other tissues in which their stimulation may have untoward effects. The agonism of the IP receptor in the peripheral arteries leads to the flushing, headache, and hypotension often seen with using prostacyclins. IP agonism will also inhibit platelet aggregation, thus increasing your bleeding risk. IP receptor stimulation in the gut may lead to the nausea and vomiting and even diarrhea. Lastly, IP agonism in the nerve cell may manifest as pain, which is commonly reported as jaw pain or extremity pain in patients that use prostacyclins. The dosing of prostacyclins follows the principle of start low and go slow. Doses are increased incrementally to achieve disease stability, increased quality of life, and tolerance of those activities of daily living. However, the drug side effects often limit dose escalation or attainment of those goals. This chart lists the usual starting doses of the available prostacyclin products and the specific goal doses, although these goal doses may be modified to meet the patient and the pH symptom goals. There are specific administration considerations for the use of parenteral prostacyclins and would benefit from pharmacist expertise in this area. For intravenously delivered prostacyclins, IV central access is preferred due to compatibility issues as well as to eliminate drug interruption and potential for unintentional bolus administration. A dedicated IV lumen is recommended. These IV infusions should be administered by an electronic continuous infusion device with a 0.22 micron filter to decrease air embolus risk. And lastly, any patient receiving continuous infusion epoprostenol or treprostinil should have a second bag, syringe, or cartridge available at all times. The diluents that may be used differ with the product that is selected. Generally speaking, the addition of a high pH diluent increases the stability of the reconstituted or diluted product. All epoprostenol products are lyophilized powders that require reconstitution. The Flowline product in particular requires the use of proprietary or comparable pH sterile diluent. Velletri, on the other hand, does not require a special diluent and may use sterile water for injection or saline to reconstitute and dilute it to the final product. Treprostinil is available as a sterile solution that does not require reconstitution, but to achieve administration rates necessary in children, dilution is often needed. Any of the listed diluents are acceptable for treprostinil. However, they each have different storage and administration requirements. Treprostinil that's given subcutaneously is typically infused by one of those infusion devices shown below. Both are ambulatory infusion pumps that allows the patients to be mobile and active. As with other subcutaneous infusions, the site of administration should be considered based on the patient's age, body habitus, typical activities, and lifestyle. Injection site pain is very commonly reported in subcutaneous infusion treprostinil. Infusion site pain typically reaches its peak around 2 to 5 days after starting the new infusion site and usually subsides about a week after that site change. It generally improves after several months of therapy and with effective pain mitigation techniques. Specific strategies for injection site pain are listed in this table below. However, none of these are evidence-based, but are a compilation of anecdotal reports of these multimodal analgesic approaches for this particular pain syndrome. The inhaled prostacyclin products, treprostinil and iloprost, have special administration considerations too. Both products have proprietary delivery devices that are mobile and battery-powered. Additionally, these devices require daily cleaning and the use of distilled water for inhalation, which may prove difficult for some resource-limited families and patients. The treprostinil device has 6 pieces that have to be assembled prior to drug administration and disassembled during cleaning in the evening. The dose is delivered over 3-second breaths, up to 9 patient-actuated breaths every 6 hours. This device must be kept at least 11 feet away from cellular devices to avoid the electromagnetic interference that is often employed with this device. Iloprost, on the other hand, requires 10 minutes of dedicated administration time, but is able to adapt to the breathing pattern of the patient, unlike the treprostinil device. Prostacyclin stability and beyond use dating is another area in which a pharmacist's expertise is needed, as there is very specific drug compounding, storage, and administration considerations. So taking a first look at our IV and sub-Q prostacyclin products, the source of truth for stability in the beyond use dating really depends on your sterile preparation guidance that's provided by the USP 797 and in your institutional policies for beyond use dating if you're using them as an inpatient. For ambulatory infusions, the drug-filled delivery devices that are on the person, meaning that drug is exposed to the ambient temperature as well as the environmental and the body heat for the duration of that infusion. And for these instances, the package insert is probably the most appropriate place for the stability and beyond use information. Additionally, the diluent should be considered as this can affect the long-term stability of the infusion, whether it is an inpatient or an outpatient infusion. For your inhaled prostacyclins, the device type and the drug source will dictate your product stability. The proprietary devices will utilize their own drug cartridges, so that package insert is the best source of information. For the non-proprietary devices, such as the continuous nebulization of epoprostenol, um, please refer to your institutional's compounding guidelines, US 787, for those beyond use dating, and take into consideration if a diluent is used as well. And lastly, for your oral prostacyclins, referring to the package insert for that stability and beyond use dating is the most appropriate approach. Another area of opportunity for pharmacist intervention with prostacyclin therapy is to provide assistance and recommendations on how to transition from one agent to another. As the drug experts, we understand the PK of these drugs the best, and we can create the safe transition plan. In the next slides, I'll outline general strategies from transitioning from IV epoprostenol to IV or subcutaneous treprostinil, and IV to subcutaneous treprostinil to oral treprostinil, and oral treprostinil to back to IV or subcu treprostinil. In the event of transitioning from IV epoprostenol to the longer-acting IV or subcu treprostinil, continuous infusions of both drugs will be running concurrently during the transition. The interval for the dose escalation of the treprostinil and the dose de-escalation of the epoprostenol will really depend on the patient's tolerance of the transition. A typical interval is about every 8 to 24 hours, and it's usually as an inpatient monitored setting. Transitioning from the IV or subcu treprostinil to the oral formulation, called Orenitram, is really a little less defined than the IV to subcu conversion. So the package insert provides a calculation for the oral treprostinil dose based on that parenteral version as shown in this purple box. The goal really is not to replace the parenteral treprostinil with the oral dose on the first day, but rather to increase the oral dose in a stepwise fashion and reduce that parenteral dose in a similar fashion. The infusion can be decreased by up to 30 nanograms per kilo per minute per day, and the oral dose can be advanced by 6 milligrams per day. So as an example, I've listed 2 patients here and their transition plan. But generally what we are looking at is a parenteral dose that is decreased by 10 to 15% every 24 to 72 hours, and the oral dose is advanced at a similar interval by 10 to 15% to the target dose. The rate limiting step in this transition is often nausea and vomiting, which may slow that up titration to the target oral dose. So in the scenario where a patient does not tolerate the conversion to oral prostacyclin therapy or encounters a clinical scenario in which the oral prostacyclin therapy is not feasible or medically appropriate, the transition to IV or subcu treprostinil is an option. So this purple box provides the calculation for this oral to parenteral conversion. For example, so if we have a 78 kilo patient on oral treprostinil of 9 milligrams 3 times a day, this would calculate out to the 48 nanograms per kilogram per minute of the IV or subcu treprostinil. To make that transition, the parenteral infusion should be initiated around 5% of the calculated dose and advanced every 8 to 24 hours until the goal is met. Simultaneously, the oral treprostinil dose will be decreasing by the 10 to 20% at 8 to 24 hour intervals until it is discontinued. So I would be remiss if I did not mention our newest prostacyclin agent that's available. This is selexipag. This oral option is a prostacyclin receptor agonist, but is considered structurally different from the prostacyclin products that we previously discussed. So the bioavailability sits around 50% and is really not affected by food, but the time to peak is often delayed with food. Selexipag is biotransformed by the CYP isoenzymes and does have an active metabolite with a prolonged half-life, which is highlighted by the twice-daily dosing scheme. The adverse effects of this drug are very similar to the other prostacyclins, with the GI toxicities most commonly seen with this route of administration. The selexipag tablets are not to be crushed, split, or chewed, which makes its application limited to the pediatric PH population. However, there is an IV formulation of selexipag that's been available since summer of 2021, but it's really only supposed to be used temporarily if the patients are unable to take oral medication. However, it actually has a very similar price point to that of an oral tablet, so I wonder how its utilization will change over time. There is some good news in regards to the investigation of selexipag in children with PH. An industry-sponsored prospective multi-centered phase 2 trial is ongoing to look at that safety, tolerability, and PK of selexipag in children with PH. It has an estimated completion date of late 2026. Also, there's a study of selexipag as an add-on treatment to the standard of care in children with pulmonary arterial hypertension, also called the SALTO trial. This is a placebo-controlled RCT that has an estimated completion date of December 2024. Now that I've been through all the PH medications in detail, I want to revisit this treatment algorithm once again. So the high-risk group is recommended to have early combination therapy initiated, whereas the lower risk group has consideration for combination therapy, but it's not as an AHA recommendation. I really wanted to shed a little light on what combination therapy is referring to and in what context should it be considered. The Ambition trial really has reinforced the combination therapy as a means of this multimodal pH treatment approach to slow disease progression and improve quality of life. Ambition enrolled treatment-naive adult patients with WHO functional class 2 or 3 pH. These patients were randomized to a combination of ambrisentan and tadalafil, or ambrisentan and placebo, or tadalafil and placebo for at least 24 weeks. The primary endpoint of this study was the first event of clinical failure, which was defined as the first occurrence of death or hospitalization for worsening pH or disease progression. The patients who received that combination therapy were half as likely to experience clinical failure compared to those monotherapy cohorts. The adverse event rates were a little bit more frequent in the combination therapy group, but there really was no difference in the discontinuation rates nor serious adverse effects among all three groups. So while the Ambition study has not been replicated in children with PH, there recently was a 2-center retrospective descriptive study of using that combination of ambrisentan and tadalafil in children. This combination was associated with improved exercise capacity and hemodynamics in children who were either treatment naive or on monotherapy before the initiation of that combination of ambrisentan and tadalafil. This trial alluded to that combination treatment up front in that naive patient or as sequential addition of the combination in those monotherapy patients that may have benefit in slowing their disease progression. The most recent recommendations that we have, that consensus statement from the World Symposium of Pulmonary Hypertension in 2018, is really to offer that upfront combination or the sequential combination of the PDE5 and ERA in those low-risk patients, and in the high-risk patients, either an upfront or sequential combination of the parenteral prostacyclin with the PDE5 or ERA. Therefore, this treatment algorithm would be modified to look something more like this, emphasizing that need for that multimodal approach in both the lower and the high-risk arms. So this is the last topic I would like to address in the management of PH in children, is the drug-drug interactions. So this chart across the top lists the cytochrome P450 isoenzymes, and on your left side is your list of pulmonary hypertension drugs. So notice that many of these are minor substrates, but sildenafil, tadalafil, macitentan, and selexipag are the major CYP substrates. Bosentan is the only inducer on this list, and it moderately induces 3A4 and minorly induces at 2C9. So this is important because it may decrease serum concentrations of other drugs that use this metabolic pathway. But despite the inducer status of bosentan, concomitant use does actually not require dosing adjustment in most cases, specifically with sildenafil. And generally speaking, with pulmonary hypertension drugs, they really should take precedence when managing those drug-drug interactions, meaning the pH drugs should not be dose adjusted to accommodate a non-pH medication. Rather, the selection of another non-pH medication that does not interact really should be pursued. Again, I recommend using the specific pH medication package insert for dose modifications if a drug-drug interaction cannot be avoided. Some other clinically significant drug-drug interactions include bosentan with oral contraceptives. So contraception is necessary with bosentan due to that embryo-fetal toxicity and the REMS program. Because of the decrease in oral hormonal contraceptive effectiveness, dual methods are often recommended um, should oral contraceptives be continued. Intrauterine devices with levonorgestrel do not require dual contraception with bosentan. Sildenafil, though, with a strong CYP3A4 inhibitor like ritonavir, should be avoided, but other CYP3A inhibitors may be utilized safely with concurrent sildenafil. Really, I would refer you back to the sildenafil prescribing information for more details on those dose adjustments. And lastly, macitentan combination with strong CYP3A4 inhibitors like ketoconazole and dual 3A4 and 2C inhibitors like fluconazole really should be avoided. So thank you for making it to the end of this module on pediatric pulmonary hypertension. I really hope that you are able to appreciate there are many different etiologies of pediatric PH and that cardiac catheterization remains that gold standard for diagnosis. The drug treatment is really contingent on that severity of disease, whereas the selection of agent really depends on dosage forms that are available and the side effects that are tolerated. Combination therapy up front in both low and high risks is really gaining favor. The side effects of these drugs are often the rate limiting factor for the dose escalation, and pharmacists do play an active role in mitigating and managing these side effects. And lastly, the drug-drug interactions may be significant with some combinations, and the management of these interactions and this complex patient population with this progressive disease really demands the expertise of a pharmacist. So moving on to the first assessment question. What is the gold standard for diagnosis of pulmonary hypertension in children? Is it A, cardiac biomarkers, B, cardiac catheterization, C, cardiac magnetic resonance imaging, or D, echocardiogram? So the answer is B, cardiac catheterization. Currently, none of the other modalities offer real-time hemodynamics of that cardiopulmonary system. Cardiac biomarkers, MRI, and echo may all be used as surrogates for potential or progressive disease, but actually do not allow for that definitive diagnosis. Assessment question 2. What is the most common side effect of sildenafil therapy? Is it A, anemia, B, headaches, C, tachycardia, or D, vomiting? So the answer is B, headaches. Sildenafil and all the PDE5 inhibitors are commonly linked to headaches. Anemia, tachycardia, and vomiting are really unlikely adverse effects of sildenafil. So assessment question 3. The bosentan REMS program monitors for the following. Is it A, aplastic anemia, B, cardiac arrhythmias, C, hepatotoxicity, or D, visual loss? So the answer is C, hepatotoxicity. The REMS program for bosentan is both for hepatotoxicity and the embryo-fetal toxicity. The other ERA agents require enrollment for their respective REMS programs due to the embryo-fetal toxicity, but not for hepatotoxicity. That is specific to bosentan. Assessment question 4. What is one advantage of subcutaneous treprostinil compared to intravenous epoprostenol? Is it A, the avoidance of jaw pain, B, reduced injection site pain, C, prolonged half-life, or D, increased blood pressure? So the answer is C, the prolonged half-life. Treprostinil has a half-life of 4 hours compared to epoprostenol's 6-minute half-life. The jaw pain and hypotension are adverse effects of the prostacyclin drug class, which includes both treprostinil and epoprostenol. The injection site pain really is commonly reported with subcutaneous infusion of treprostinil, so it is not an advantage. And for our last assessment question. So a 2-year-old patient has been recently diagnosed with the ABT negative low risk PH. What would be the best treatment combination to initiate? Would it be A, amlodipine oral with bosentan oral, B, bosentan oral and treprostinil inhaled, C, riociguat oral and epoprostenol IV, or D, sildenafil oral and bosentan oral? So the answer is D, sildenafil and bosentan. The combination therapy in a low-risk patient should really be considered with a PDE5 inhibitor and an ERA. For a 2-year-old, sildenafil and bosentan both have liquid or a dissolvable dosage form, and these are the two agents most studied in this young of a patient. Amlodipine is not an option as this patient is ABT negative. Inhaled treprostinil would not be feasible in this young of a child because of the delivery device. And this patient is not in a high-risk group, which would not warrant the use of IV or subcutaneous prostacyclin. There really is not enough experience or data with riociguat in a patient with PH to make it a first-line choice for a pediatric patient. I've put together a handful of slides with additional information that you might find helpful for future reference. So this slide features some additional therapies that are being tested in our pediatric PH patients. I also included this table that has the drug approvals for all of the pediatric PH medications, not only for the USA, but also for the European Union and Canada. I just thought it was very interesting to compare and contrast what was approved and what is unapproved in the various locations versus children and adults based on the agents. This slide and the next contain the various RCTs for the drugs used in PH. They're all sorted by their study acronym name, so you can see that here in the second column. I also tried to include whether or not children were included in the RCT, as well as providing the citation with the DOI for easier lookup should you want to investigate it further. And lastly, this slide and the next are my references that were used to inform this presentation.